Hello and good afternoon. I'm just wonderfully surprised with this crowd. I never knew how popular lobster rolls were here, and had I known, I would have brought in a few more. We'd need a bigger room. So thank you all for coming. I'm Lindsey Kerr. I'm new to York Hospital. I came here from Northern Light in Bangor, where I was practicing for 10 years, and most of my practice prior to that was in academic medicine. I'm trained as a urologist. I'm boarded again in a different specialty called female medicine and pelvic reconstructive surgery. And that's what we're going to talk to you about today. I've had this wonderful opportunity to join the faculty at York Hospital. You really have an incredibly special hospital in this town. I don't know, most of you probably realize it, but having worked in many institutions before, this place is just really wonderfully, specially different. And I think we're really fortunate to have a hospital like this in the state of Maine and in this part of Maine that you all can take advantage of. So we're going to talk about the pelvic floor today and pelvic floor disorders. We've set up we're launching a very nice clinic for you all, and there will be cards, and I think I'm going to have to put on a couple more schedulers when we get done here today, because you all are going to have way too many questions you need answered. So I'd like to talk initially about why is pelvic health important? Why do we talk about it? Why is it of interest? And so part of the reason that pelvic floor kind of was ignored is that it's shared by several different specialties. So you have gynecology, which takes care of the middle compartment, urology taking care of the front half, and colorectal GI taking care of the back half. So it wasn't until we had these 3 specialties, 4 specialties, 5 specialties talking to one another that we actually could have a reasonable discussion about what goes on in the pelvis. So why is this so important? 22 million Americans are wet. I'm so sorry. 85% of those 22 million are women. And I'm sure some of you know who women are who are wet. I'm sure you're not here today, but I'm sure you know some who are wet. Fecal loss impacts 9% of women. I mean, who wants to be losing poop? That's fine for babies. For the rest of us, that just isn't something we think that we should ever be burdened with again, correct? Right. Pelvic organ prolapse, things coming out of the vagina, occurs in 15 to 30% of women, and it requires multimodal therapy. There isn't just one solution for it. Incontinence is a leading reason for nursing home placement. Do you really think that you'd want to have to be put in a nursing home? But that's what many families come to when it's the straw that breaks the camel's back for people keeping family at home. It's linked to falls and fractures, and those are never good. If you slip on the way to the bathroom, you fracture your hip, you've got a 20% chance of never getting out of bed again. That would be hideous. It's associated with depression. So people who become wet get depressed, and they put on weight. No one wants to be sad and chunky, right? So economic impact of this disease, $19 billion a year in direct and indirect costs for Medicare, right up there with arthritis. So it's expensive to treat. It's expensive to take care of. Behind osteoporosis, behind overactive bladder, and behind breast cancer. Cancer treatments are certainly exponentially more expensive per patient, but per patient who has incontinence, it's an awful lot of money that we're spending on trying to get people drier. So who goes into what office? Most people who end up talking about their leakage are in their primary care's office. If you ask a physician who asks the question, first, of course, we all say, well, you know, they came into my office and I asked them about incontinence and they said they were wet. Okay, that's the blue bar on the left, and patients rarely ask. If you go to the next section over and ask people who brought up the incontinence, it's the patients who bring up the incontinence with the doctor. They don't get asked. And it's true. If you look on the questionnaire, we ask you, are you wearing a seatbelt? Are you smoking pot or chewing, cannabis gummies? Do you wear your bicycle helmet? How many wear your bicycle helmets when you, okay? So is that horribly relevant for us necessarily? No. We want to be able to tell people our story. We want to be drier. We don't want to be leaking stool. We don't want things hanging out that don't have to. So what is the pelvic floor? Is it red cherry? Is it made of pergo? Or is it something more flexible? We're going to talk about the anatomy and the physiology of the pelvic floor, what happens with aging or disease, And how can we preserve what we have and not lose something going forward, right? So the pelvic floor is truly a bowl, okay? And it's a bony bowl. It is lined by muscles, which you see on the left side. The white areas there in the center on the left picture are ligaments that hold those muscles together and hold things up and in. And then you can see just the front portion of that bowl has 3 exits in women: rectum, vagina, and urethra. But they're all very forward in that pelvis. The back of the pelvis is the tailbone and many more ligaments, and where the nerves come out and the blood vessels come through. The figure on the right-hand side is looking up towards the pelvis. So again, you can see there's some really, really sturdy muscles that hold everything up and in. Now, if you compare ourselves to animals, they're on all fours. We have to come up with a lot more coordinated strength to keep our organs and everything else back up and in and prevent. And not something we do on our own, but that's the way we were built. So these muscles are particularly strong and well suited to carry out the job that they need to carry out, but not so well suited when things aren't going so well, right? So what's a pelvic floor disorder? Well, I kind of put them into 2 different categories. It's abnormalities involving the organs of the pelvis, their attachments to bones, muscles, or ligaments. It could be structural. The bladder could drop. The sphincter doesn't close like you'd want it to. When you go to urinate, it doesn't close afterwards. It could be functional. That's not due to a muscle, but it's due to how that organ operates. It could be constipation or diarrhea that comes from the colon. It could be a bladder that is hyperfunctional. It contracts way too often, way too frequently. Well, what about male pelvic floor disorders? And I know we have a few men in the room, and I appreciate you coming today. Men don't have prolapse by and large, because that third organ, the vagina, makes room in the female pelvis for things to come through. Men, however, have very significant issues with urination, both leakage and holding onto the urine. And likewise, they can have some of the same issues with the bowel that can impact what goes on in the bladder. And we have a really strong, well-educated, well-trained urology group here at this hospital who will be happy to see you all for that. I'm also happy to take any questions that you have. There are parts that definitely overlap for us there. Pelvic organ prolapse or incontinence. The prolapse occurs when some organ moves out of its normal position. So this could be the bladder moving out into the vagina, the urethra moving down into the vagina. It could be the uterus coming down, or bowel, either small or large bowel, coming up and then pushing down and out. Voiding dysfunction and incontinence is considered the involuntary loss of urine or the inability to retain urine. You don't have control about when it comes out, or you don't have control in being able to get it out. It could be either way. So if we think about what happens earlier in life, we have this very nice ship that's held up by the pelvic muscles, the water in the pelvis, and then we have these nice little ropes on the side that keep the ship in place, right? So what happens postmenopausally? Well, the pelvic floor muscles relax and they thin out, and then sometimes the ligaments have been stretched with childbirth and other things over time, and they'll break. And so we end up with that ship listing, ligaments and the organs of the pelvis coming down and out rather than staying up and in. But it takes 2 systems in our pelvis. It's the muscles and the ligaments that help keep things up and in. And usually we don't lose them both at the same time. It tends to be a more gradual process. If we talk about prolapse, on the diagrams on the right, you can see that there are 3 different organs that are coming down and through. So the first one here, that bladder, is pushing down on the urethra, pushing down the vagina and pushing out. You can see that here. The second one, the rectum, is pushing into the vagina, and it will push the vagina down and out. And the third is small bowel here. So there are actually 3 different compartments outside of what's normally in the vagina that can push their way out and push the vagina in front of them to get out. You can also have uterine prolapse. So the uterus loses its support in the pelvis, and it will start to migrate down, and sometimes the cervix, I can feel the cervix right at the entrance of the vagina. Sometimes after a hysterectomy, you think everything got pulled back up and in, the vagina in and of itself can turn inside out. And none of those things are particularly comfortable or make any of you warm in the heart, I'm sure. So what are the causes? Well, I always say blame your firstborn. It's easy. It's what we usually do. And as firstborn, you've been blamed by your especially your mother as well. So, but childbirth definitely in that last trimester, that pressure on the pelvis. Think that fetal head comes up with a lot of pressure on the pelvis, and that tends to decrease over time how those muscles can work and the blood supply to that pelvis and the nerves to that pelvis. Pelvic surgery, other organs that were taken out can affect prolapse. Obesity, we know that that in and of itself with the weight on the abdominal organs can help push things in and out. Menopause doesn't really cause it, but it just kind of lets come to the forefront the prolapse that would be developing over time. Importantly, this is hereditary as well. So in addition to blaming your firstborn, you can also turn around and blame your parents, because most of this prolapse has a hereditary component. If things were stretchy and your sister has prolapse and your mom had to have an early hysterectomy, that might be your case as well. What do people complain about when they have a prolapse? They'll complain about a heaviness in the pelvis. They'll get back pain. They'll get a bulge from the vagina. Maybe a problem urinating. Some women, when the prolapse comes out, find that the urinary stream will spray or splay. It can't come out the urethra any longer, okay? Also, the urgent need to go when that bladder gets particularly full because you're not doing a good job emptying it. You can't. If we have a prolapse at the posterior compartment, many women will complain that they have to strain when they go to poop. The poop gets stuck. They might have to put 2 fingers in the vagina or pull one cheek up in order to get that stool to come out of the rectum. And that's annoying to say the least, right? It's not just constipation. You thought with the prunes and the Miralax that you'd be pooping fine, and it gets down there and it gets stuck. You're like, what? Come out! I'm ready. Get out. I just had a really good time last night looking at all these slides about, urgency, frequency, and urinary incontinence. So this cat's up a lot at night having to scent Mark. And I brought this question up one time with a group of medical students, and this was quite some time ago, but I asked my medical students why we had a bladder. And the first answer I got was that, we wouldn't leave a scent trail if we were able to hold on to our urine. That was probably smart thinking, right? And then I got one statement from one of the guys who said, we could climb up in a tree and pee on the saber-toothed tiger, and they would run off. Well, as part of the population that does not have aimable artillery, I would have been annihilated. I can't aim the pee. So, not why we have a bladder. So we have a bladder so that we can socialize. We don't leave our scents everywhere we go. People who are filled with urine that they've leaked don't smell particularly good over time, and that's something we all want to avoid. Holding onto our urine lets us socialize. We can excuse ourselves when we want to go to the bathroom. Otherwise, we can continue with our conversation. We don't have to go. So if the bladder can't hold, a couple reasons it may not be able to hold, okay? The bladder may be overactive, contracts too often, may be small to begin with. Pretty unusual. There are a few neurologic reasons for that. Alternatively, the outlet doesn't stay closed, okay, for whatever reason. It might be damage from surgery, might be a nerve damage, might be some kind of destruction that outlet, that sphincter has undergone. So that's the reasons for bladders not storing. Now, how about bladders not emptying? That also happens. Okay, the bladder may not empty because it doesn't come up with a good contraction. How are you going to know the difference? You don't. You have to come see me or one of the urologists to figure out what the difference is. Some people, it's learned behavior. They just have a difficult time having their bladders contract when they need them to in the bathroom. It could also be because of the outlet. There could be narrowing or stenosis of the outlet, or there could be something in the way of that urine prolapse. When we talk about dividing up urinary incontinence, we like to put people or their incontinence into various categories. And you might have one or two or all three of these. Or you might have a fourth one, which isn't on the slide, but we can talk about that one afterwards. So stress leakage occurs. With an increase in abdominal pressure, urine comes out the urethra when you don't want it to. Examples: coughing, sneezing, lifting something heavy, jumping on the trampoline with your grandchildren. If you ever wondered if you had urinary incontinence, take 2 jumps on a trampoline. You will know it's one of the best provokers. I think I should have one in my office for people who just wonder whether or not they leak. It seems to let go with that. Urge leakage. You have the urge to go and you cannot make it to the bathroom on time. You turn on the water at the sink. Oh, gotta go. You pull into the driveway, get the keys out for the house. Can't get to the house because the bladder says, I need to go. You put the key in the door and it's down your leg, right? That's also a problem. Your bladder doesn't want to wait until you get to the bathroom. It's recognized that it's going to go now because you're close. That doesn't work, does it? We want to be in the bathroom. Overflow incontinence. It's the inability to empty because there's something in the way. In women, that tends to be prolapse. In men, that tends to be the prostate. So what do we do for stress urinary incontinence? If you come into my office and we've done a good interview, we've done a good physical examination, we've talked about your pad use and what's getting you up at night and some of the other things, the couple first things I like to talk about is regular toileting, correct? Going to the bathroom on some regular basis. You might need some form of exercise therapy, and we've got some really good physical therapists in our community, one who's here today. That's a great opportunity to learn how to rework those muscles of the pelvis, and you can actually retrain those pelvic muscles to hold that, to tighten up around that sphincter and keep you dry. We know from diet and weight management that a 10% weight loss can increase how dry you are. That doesn't mean that I want my tiny ladies to lose, 5 or 6 pounds, but you can imagine if you're carrying quite a bit of weight, that might only be 20 pounds. Which might only be it's only 5% of your weight. That wouldn't be much of a change, but it could be a significant change in how dry you are. And then can we do outside of what you can do, or you can do working with a physical therapist, or we can teach you in the office, and those would be the more surgical procedures. Bulking agents are something that are put into the urethra to get it to close better. Slings we put underneath the urethra to get it to stay up and appropriately in the pelvis. And then there's a couple other treatments, novel treatments out there, one of which I'll go through today called radiofrequency treatment. So the bulking agent gets put in the operating room. And if you imagine that this is the bladder, then we take a very tiny needle, and you're asleep, okay? I'm not provoking you in my office, but you're asleep. We use a scope I can see on the outside. Right here, I put a little tiny needle on here, and then I can push the sides of the urethra back together again. You think about it this way, that urethra stays closed, much like if you take a sip of water, you can hold it inside of your mouth. It doesn't come dribbling out the corners of your mouth. If you couldn't hold that water and you kind of dribble a little bit, a bulking agent would push your lips back together again. Now, I don't do bee-stung lips. I do bee-stung's urethra, but you are asleep for that, and you wake up and the bee's gone. Okay? So that's a nice little one. Stress incontinence treatment, the gold standard at this point in time is called a sling, and it can be put in a couple different ways. There are probably 140 different incontinence procedures named after various men in our surgical history. But these slings are really fit in very nicely. A small incision in the vagina, 2 tiny poke holes. You can still wear the bikini here and here, and then that sling fits underneath the urethra. Now, it doesn't pull the urethra shut. We don't need to be yanked up by our armpits to stay dry. It just, when we move, it gets the whole urethra to move as a unit and to stay closed and not open back up. That's about a 20-minute procedure. The products that we are currently using last about 500 years. They're going to outlive me, I'm sure. And those were 2 different approaches. One goes through the tummy, one goes through the pubic bones. Works really well for gals. There's also collagen denaturation, where we stimulate the collagen in the pelvis and it will reform and tighten up that urethra. It's called radiofrequency treatment. That's fairly new. I think there's just a couple groups who are offering at this point in time. So some very good treatments for stress leakage if you can't be managed with a little change in your schedule, some pelvic floor exercise, and some thinking about behavioral modification, what you eat and when you drink, and losing a little bit of weight. So those are good options for stress leakage. Now, some people have both. Some people have stress leakage and urge leakage. What do we do then with the urge? Besides run off to the bathroom. So again, interestingly, exercise therapy works really well for urge leakage. So if you think about it, you want to tighten up that pelvic floor, all right? You're closing that sphincter, but it's actually not getting that sphincter to be stronger. What happens is when you do those exercises is that sphincter sends a message to the bladder. When it tightens, it's time for you to make more room for urine. I need you to hold more urine until she can get to the bathroom on time or he can get to the bathroom on time. So it's not just that sphincter closing, but it's a signal to the bladder to relax and accommodate and take on more urine. Again here, diet and exercise, dietary management, fluid management, what you're drinking. There are a lot of irritating things we take in the course of a day. You may not be drinking enough water. That sounds a little counterintuitive, but when you drink very, very little, the concentrated substances that are in your bladder irritate the bladder. So let's say you have trouble with urge and urge leakage, but you have a couple of coffees in the morning. Well, what is in that coffee can irritate that bladder. Let's say you cut down the coffee a little bit. You added a glass of water. Now, much more fluid than you were used to, but now what's in the bladder with the coffee doesn't irritate the bladder anymore because it's dilute. So very important to dilute out what we're eating and drinking. A little bit of weight loss. Medications, in the past 20 years, we've had 8 new medications for urge, incontinence, urgency, frequency on the available to us. And I'm sure you've seen the pink slacks that were running around on the clothesline. That was one drug. There are a whole host of medications out there that work really well to help with urgency and frequency. In the past 5 years, we've gotten one new drug that works somewhat differently, and I've really liked using that one because the other group of 8 tends to give people dry mouth and a little bit of constipation. Well, a little bit of constipation is fine if you normally poop every day. If you normally poop every other day or every third day or every fourth day, a little bit of constipation totally binds people up. So I have to also work with the constipation because when the colon doesn't work, the bladder doesn't want to work appropriately. Women who tend to have constipation tend to have worse urgency and frequency. Women with diarrhea tend to have worse urgency and frequency. So part of what we need to manage here also has to do with what we do with the other big organ in there, and that is the colon. And then we have some what's called peripheral nerve stimulation, where we can use a very, very tiny needle. This is actually based on a Chinese acupuncture site, which was described. So we can put a very small needle next to the ankle bone here, and that signal would be taken electrically stimulated. That signal will be taken in, relays in the spinal cord, goes up to the brain, goes back down to the bladder, tells the bladder, you need to hold more urine. Crazy, isn't it? I thought that was totally crazy. So this therapy is done in the office with a tiny, tiny needle, little box. You come in, please bring a book that you really like to read for about 30 minutes. That's how long the therapy takes. It's once a week for about 12 weeks, so it's a visit, but you're not going in for examination. You can go in and do something fairly relaxing. And then we need to see you back about once a month afterwards. So eventually I think we're going to see a permanent implantation for this. That's something that you probably can get to use at home. That hasn't come up yet, but I'm sure that is where they say that they're taking this. Also good for the bladder. For those who fail medications for urgency frequency, who aren't getting any further along with dietary modification, with weight loss, with pelvic muscle exercise, there's Botox. I always wanted to find the Campbell soup can when I was growing up in the grocery store that was exploding with Botox. I just thought that would be really neat if I could run up to the head grocer and say, look, Botox, do some botulinum toxin, do something with this can. Now I can use it pretty much anytime I want to. Botox is a fabulous, fabulous poison. It's the most potent neurotoxin known to women. This is not meant for your forehead always. There are lots of other places we can use it, and particularly for overactive bladder, it is a great medication. So it will keep the nerves from putting out the stimulatory signal for the bladder. It's approved by the FDA. And I will inject it into the bladder with just a little bit of dilution, and we put it in kind of in a rectangle configuration over where the two ureters coming down from the kidneys. It's some very tiny injection site. We put in a little less than a tablespoon of medication into the bladder. In this particular application, that medication will last from 6 to 9 months, although some gals will get out to, as some men will as well, get out to 2 years with it. So the great thing about Botox is it does wear off. The bad thing about Botox is it wears off as well. So initially, we do see it's a little bit more difficult to empty the first week or so. Afterwards, it gets much easier, but you can hold lots more urine. Really changes up where you can go, what you can do with the Botox. But unfortunately, it does wear off. So we have to redo this again, maybe in 6 months, 9 months, a year, something like that. A more permanent implantation is something called an InterStim. And this device is a little tined lead, which gets implanted in the back. Again, if you had to have this, you're asleep for this, you're not. We put this little tiny wire into the back. It sits next to the nerve that takes the sensation, again, from the bladder up to the brain. It tells that nerve either calm down, because we can use it for people who have urgency, frequency, and leak, or people who can't urinate. In that case, the signal is time to get the bladder to come up with a contraction. And then there's a little tiny battery, it's about this big, that gets implanted just over the, above the hip and slightly midline on the back. So you've got just a little bump just below the belt line that you can feel. This takes a little bit more to get in than the Botox, but it is something that can last for 5 to 10 years without being replaced. And they've just come out with, another company's just come out with a smaller battery and a rechargeable. So with this particular one, I had to go in and change that battery every 5 to 10 years. This one you can recharge on your own. And maybe you can recharge your cell phone at the same time. I haven't seen the specs yet, but wouldn't that be nice? I'm going to charge both batteries. There you go. Okay, so we're going to switch from incontinence to prolapse. We've talked about how we treat urge incontinence, how we treat stress incontinence. Now let's talk about the other piece that comes in there often, why people are coming into my office, and that is things are not staying up and in place any longer. So there are 3 levels of support in the pelvis. One comes from these ligaments that come down from the spine and the pelvic sidewall. The second goes side to side muscles, side to side in the pelvic sidewall, and they will hold on to muscles on the side. And the third is around the sphincter and almost at the opening. Each defect has a slightly different repair. You do not need to know this. I need to know this, okay? So we will approach how to take care of your prolapse based on which compartment has let loose. Sometimes one has, sometimes one half has, and the next one has. Sometimes all 3 have let loose. The all 3 is pretty darn unusual. It does happen. We don't see that often, but any one of those 3 can let loose. And if they do, we can easily make a diagnosis and figure out what would be best for you. And sometimes nothing. You can have a prolapse. You don't have to have it repaired. If you can poop and pee and it goes back in and it doesn't bother you, I wouldn't tell you to get it fixed. No, you don't need it fixed. If it's coming out, it's getting in the way, you can't pee, you can't empty your colon, we need to think about doing something about it. So pessaries can be useful for getting the vagina back up and in, and they work quite well for some women. Many women find that they don't want to be wearing something in the vagina day in and day out. So that's pretty much the non-surgical approach. You cannot retighten muscles for prolapse much. Doing those exercises is not going to draw everything back up and into the pelvis. They just won't. So pessaries can work quite well. Some exercise can make some difference. What has been absolutely wonderful that we've added on here, and I want to tell you that this is incredibly special, you all have a robot at this hospital. It's your hot robot too. So this particular robot has totally revolutionized what we can offer for surgery. Laparoscopically is a way to get into the abdominal cavity or into the chest and look with scopes using a television screen to work. And that has been the way we've done surgery for the past 15, 20 years for many operations. The problem is that you don't have a three-dimensional view. So for complicated, more difficult surgeries, and prolapse is one of those, not having that three-dimensional view was very important. With the robot at the patient bedside, I can sit at a console and play the organ. I can have 3 instruments. I use my fingers and I use my feet. So very much like playing the organ. It's a pretty steep learning curve. I'm over it, so you all will not have to worry about that. But it's a pretty steep learning curve to coordinate 2 feet and 2 hands, and 3 instruments, and a camera, and focus. I have a really wonderful team at York Hospital that helps me out. And so very complicated things like putting in this mesh, sewing it in place in the abdominal cavity is quite easy. So the particular operation, if things are really coming down and out and inside out, is called a robotic-assisted laparoscopic sacrocolpopexy. Yeah, 3 times 5. SCP. But the important piece here is what that robot can let us do that makes surgery safe for you and really will speed up your recovery tremendously. Because to do this particular surgery, I need just 5 little tiny, tiny incisions in your abdominal wall. That's only that much of an incision. And we can get down there, get a nice piece of mesh, wrap it around the vagina, pull the vagina back up again. That's hernia mesh. And then we tack the top of the hernia mesh to the front of the sacrum onto a ligament. It's not put into your bone. It's not put into the nerves. It's put into a very smooth, very strong material which overlies the spine. And now your vagina is an innie and not an outie. I might like to drive an Audi. I don't want to have one. So in summary, this has been a really wonderful program, unique to York Hospital. We've got a really wonderful environment in which to offer these services, and we really are looking forward to your questions, your answers, to seeing you, to not seeing you if you don't want to be seen, but I'd be more than happy to entertain any questions you have at this time. And I appreciate all of you coming today. I know it was cold and windy. I'm sure that about half of you in the back never got a parking space at the library. We told the police department not to ticket you for this special event. So if you have any tickets, we'll have to talk to the police for you, I suppose. So thank you. So although I'm happy to take questions, I realize some of you might not want to ask them. So we have pieces of paper. If you'd like them written to write down your questions, pass them along to the side, and we'll be happy to answer those of you who don't. And, if you don't want to raise your hand, that's fine. I'll be happy to talk to you afterwards. Yes, ma'am.
Any new exercises besides Kegels that are important to know about?
I'm going to let my physical therapist back there talk about any new exercises besides Kegels for incontinence. Do you want to answer that? Any new exercises besides Kegels? Introduce yourself, please.
Hi, I'm Kristen Zames. I own Oceanside Physical Therapy, which is a pelvic floor clinic in Stratham, New Hampshire, just south of here. Any new exercises? So Kegels is half the battle anyway. So a Kegel is just the contraction portion. What I would recommend is to start doing, see if you can do a vaginal lift on the breath out. Most people, what we work on initially is they try to do it on the breath in and they're sucking in. So do it on the breath out. The other thing to fire your pelvic floor is to sing. So use your voice. So if you go low tones, if you hum, your pelvic floor will drop down. If you go high, it should tighten. So sing in the shower and go, and you should start to feel a little lift. So there's a ton of exercises, but those are my suggestions to start.
So Kegels, the description came from a surgeon long ago who described this particular kind of exercise. And it's true that it got lumped into a whole host of things that we do. One of the wonderful things that you will get when you go see a physical therapist or someone who's trained with this is that you get feedback. So in addition to contracting these muscles, you're working with a coach and you can watch your progress on a screen. So if you contract the wrong muscle, it'll show on the screen. If you contract the right muscle, it'll show on the screen. And so it's a combination of contracting the right thing, relaxing the right thing at the right time, and not contracting the wrong thing. one of the ways I judge what strength the pelvic floor is by asking women to come up with that contraction, and I can feel the strength. But what I ask them to do is think about you're out in public with your girlfriend, with your daughter, with your husband. You're at a concert, it's really quiet, the symphony is not started yet, and you think, I'm gonna pass gas. What do I do? If you contract that muscle that keeps you from passing gas, that's a much stronger muscle than the one around the urethra, but it's really easy to identify that muscle. You contract that, you're identifying the correct muscle. And I like the singing in the shower because that's the only place anybody would want to hear me sing. So, good question. You had one here.
Hernia, the inguinal
Inguinal hernia. Yeah. So inguinal hernias can occur in people who have prolapse, and people can get prolapse that don't have inguinal hernias, but it's part of the same process where the tissues start to loosen up. Hernias in women don't tend to get back far enough in the pelvis that they need to be taken care of by me. If they need to be taken, they should always be looked at by a general surgeon to decide if it's time. It will never be time, or it might be time in the future to have something fixed. And stretchy tissue. So if you have a hernia and have stretchy tissue, you might be at risk to having a hernia develop somewhere else. So some of my gals come in with pelvic prolapse. They've had an inguinal hernia. They've had an umbilical hernia repaired. Yes. Yep. Yes, ma'am.
Could you speak a little bit about fecal incontinence?
Fecal incontinence can have several different causes. So the first thing we want to know is what's happening with the rest of the transit of the stool. Is it slow? And I do this because it goes up your right side, across, and down your left side. So in fecal incontinence, are you losing stool because that transit time is too rapid? Are you losing stool because the sphincter doesn't close? Are you losing stool because there's not enough room in the rectum? And that last one is fairly common in women who have pelvic irradiation, okay? If you're losing stool because of none of those, that sphincter is not holding you, then there are a couple different treatments for it. There is this particular interstim can work for that. There are bulking agents that can be used in and around the rectum, and there's a sphincter overlap procedure that can be done. So that probably will answer enough for now, okay? Happy to talk to you about it later. Yes, in the back.
One of the slides mentioned hormonal therapy.
Oh, and I didn't say it, did I?
I didn't remember you talking about that.
So we have receptors, men and women have receptors for hormones pretty much in every cell in the entire body, okay? So as we get older, those hormone levels in women do drop off. So without function of the ovaries, drop off of the estrogen and progesterone. And when those receptors drop off, some of the things that keep us drier, thickened muscles, thickened walled blood vessels, thin out. When they thin out, then there's more of a chance of getting some pelvic relaxation and much more chance of getting incontinence. So replacement, and I tend to use replacement intravaginally. I don't need to have my patients have estrogen exposure everywhere. We tend to use estrogen, but I really need that exposure in the vagina to help bulk things back up again. Yes, ma'am.
I know of 3 people who have had the mesh, and it has not worked. It's that one of them had to redo it, and it still didn't work. So what?
So I want to differentiate the mesh into 2 different piles, okay? About early 2000s was when we saw, yes ma'am? Okay, about early 2000 is when we saw the most consistent use and availability of mesh on a commercial level for stress urinary incontinence. That particular mesh was put in to help close up that urethra when you cough, strained, lift something heavy. And I mentioned there are about 142 plus different incontinence operations. The reason that there was not 2 or 3 when I came through is because nothing worked well. In terms of what works well for incontinence, the sling is the best surgery we have, and a sling made out of polypropylene mesh has been done tens of thousands of people worldwide, and it works the very best for stress incontinence. There's absolutely no doubt that some people do require a second operation. There's absolutely no doubt that some surgeons don't have a good idea about how well the mesh works. There's no reactivity to that mesh in the human body. It is inert. The second piece of mesh was what was used transvaginally to repair prolapse, either the top of the vagina where the uterus used to be, the anterior, the posterior wall. Those at this point in time have all been taken off the market. In some cases specifically, that mesh caused real problems. And if I think about this, and this is why we didn't use it in that particular application, a very large volume of mesh going into an environment that is not completely sterile, and the vagina is not completely sterile, has a risk of getting infected. And when those meshes became infected, they would spew into the vagina. And so I've taken out a lot of transvaginal mesh that I would have never used in that particular application. Having said that, we don't have a really wonderful product for prolapse that can be put in through the vagina that holds things back up in it. Because if you think about it, I mean, I love to use a robot, but it would be easier, I think, for patients if we had something that could be placed through the vagina to lift it back up and in. So the mesh did a good job with lifting, but it was stiff, and vaginas spit it out. So, yes, ma'am.
How do urinary tract infections relate to prolapse and incontinence?
So urinary tract infections can occur when bacteria can make it down the urethra and into the bladder. So if we step back and say, okay, well, how does bacteria get down the urethra? How does it get down when I'm age 65 and it never found its way when I was 35? When I'm 65 and I have sex maybe twice a year. Okay, when I'm 65 and I have sex twice a week, but I used to have sex twice a day when I was 22, I would have thought that I've had a bladder infection when I was 22. I didn't, but now I have them now. So there's another really protective effect for estrogen, and that is it does beef up the urethra, lets that urethra close. It changes the pH of the vagina so that the vagina is more hostile to bacteria that want to grow and cause a bladder infection. It changes the vagina's milieu in a different way. It makes it much more accepting of bacteria that keep us from getting bladder infections. So bladder infection is a balance between what happens in the vagina and then what can get down into the urethra. So when we look to treat chronic UTIs, we're looking to not only make the bladder a happier place, but also make the vagina a less happy environment for bacteria. Yes, ma'am.
What's the correlation between falls and all of this?
So the correlation, falls and fractures and incontinence, most of that has been people trying to get to the bathroom on time, and especially at night. So you're at greater risk if you're trying to scramble with a bad urge to get to the bathroom of tripping over something and falling and fracturing something. So, and even simple things like are the carpets in your home fixed to the floor so you won't slip on them? Is the bed fairly close to the bathroom? I've had people who can't make it to the bathroom at night, but if we come up with a bedside commode for them, they're not at risk for having a fall. They can empty, and then you can take care of the bedside commode in the morning. Doesn't sound so great, but if it beats fracturing your hip, it's a really good decision. Yeah. Yes, ma'am.
I'm confused about prolapse. I think I thought that the only thing that could come out was a hemorrhoid. So
a hemorrhoid is, yeah. Well, how would you know? I mean, if you look down there and you got a bulge, did anybody see fried green tomatoes? Yes. There's this wonderful scene. There are many wonderful scenes, but the one of them I really like is when Kathy Lee Bates gets together with her girlfriends, and they're supposed to take off their underwear and stand and look with a mirror down on the floor and stand and look, between their legs up at their privates. So when you look at your prolapse, you can't tell if it's bladder, you can't tell if it's uterus, you can't tell if it's rectum, you can't tell if it's large bowel or a small bowel. Hemorrhoids typically form in the rectum, and they're enlargement of blood vessels that are bringing blood back to the heart. You actually can have prolapse of the rectum as well, coming out the rectum. That's pretty darn unusual. But yeah, I mean, where would we have learned about this when we were younger? You know, I have not taught a 6th grade health class yet, but that might be somewhere to go. Yeah.
And I have one more question.
Yes.
Do you ever use D-mannose, or do you?
So for bladder infections, there are some really there are other good choices besides antibiotics. I think for a short-term treatment of a bladder infection, antibiotic is a very reasonable choice. We want to use it for a fairly short period of time, 5 days, maybe 7. I don't like to have my women on it 10 or 12. Men, we tend to use it a little bit longer because we have to sterilize the prostate as well with the antibiotic. D-mannose is a compound you can pick up over the counter. It inhibits bacterial growth. So it's reasonable to try to prevent bladder infections. Another one we use is cranberry extract pills, although there's only one currently on the market that works really, really well, and that's called Ellura, E-L-L-U-R-A. There's an 800 number and a website. It's the only proven cranberry extract pill. So cranberries, blueberries, blackberries all have a substance in it that keep bacteria from growing. You have to have it concentrated enough. So just cranberry juice can be difficult to drink enough cranberry juice that will be effective, right? I mean, I could eat enough blueberries to be effective, but that would cause other things. But cranberries, blueberries, blackberries all contain this particular procyanthin that works really well to keep bacteria in check. Yes?
Just about the D-mannose,
Yes.
which I am actually using. It's not clear because it's listed as a supplement how much to use or how frequently or how long or whatever.
There are many supplements out there for bladder health. D-mannose, Ellura are both considered supplements by the FDA, so they don't go through the same rigorous trials that do antibiotics and other drugs that we have. And so you don't know. You don't know if you have a particular effective pharmacy that's putting together the D-mannose or what the dose is. It's really trial and error. Because there's no, I hate to say this, but because there's no money in it, we will never see studies on it. Well, what an absolutely fabulous audience today. Any other questions, you can write them down, leave them here. There are cards up front. Be happy if you'd like to take one. You can also call back to our friends at York Hospital to discuss with them anything that you wanted to bring up, either a phone call or something. We're not too far away, just across the street. Thank you for your time. I hope you enjoyed your lobster roll.